I'm Kirk Jobe. I'm a neurosurgeon, and I'm very happy to work with two very good epileptologists. And so basically, you have neurologists and you have neurosurgeons. Neurologists treat diseases of the brain and nervous system with medications, and neurosurgeons treat them with surgery. Ordinarily, the two fields are, you'd be surprised, but they're somewhat of a distance from each other. In training programs, oftentimes there's even animosity. Just kidding. But anyways, neurologists see themselves as one area of taking care of neurologic disease and neurosurgeons another. Epilepsy is one of the few areas where neurosurgeons and neurologists still continue to work very closely. And I just show this slide because the first known documented surgery for epilepsy was in 1886, and that was performed by Victor Horsley in conjunction with Jackson, who was a neurologist. And this shows you the development of epilepsy surgery at each stage. 1909 with Krauss and Forster in Germany, 1928 Penfield and Jasper in Canada. All are teams of neurologists with neurosurgeons to accomplish the goal of taking care of epilepsy. The key, I think, as you saw in Dr. Passaro's lecture just a second ago, is that we still have that team approach here nowadays. The neurologists come to the OR and work with the neurosurgeon at the time of surgery to cure someone's epilepsy. Early on, 1951, one of the first published series using EEG intraoperatively, they had a 30% chance of curing someone's seizures in the operating room. Then data from 1970 from UCLA, where Dr. Passaro had trained, showing 52% seizure freedom. And finally, some of the newer data, 76% seizure freedom. So it's come a long way. And I think I'll show you as we go through these slides here that surgery is a good option for patients that have failed medications in some cases to cure someone's epilepsy. So Dr. Passaro mentioned the medical treatment of epilepsy, and here we have bromide being used as early as 1857. As he said, phenobarbital developed around 1912 or 1919 is sometimes it's dated. And then finally, Dilantin being developed in 1938 with the advent of World War II. Since that time, there's been many different variations and improvements where the side effects of the medications have been improved, but the effectiveness of the seizure medications tends to remain the same. So how do we know who will be controlled with taking medications, whose epilepsy will be controlled, and who would possibly need to be considered for surgery? So despite best medical treatment, about 30% of patients will have seizures that are uncontrolled with any of the medications that we have, in the older ones or the newer ones. So how do we know which patients will fail those medical treatments? So let's say you're just newly diagnosed with epilepsy, you start a medication. How do you know that you've failed medications? As Dr. Passaro mentioned, you should be seizure-free for a year to be able to say that that medication is working for you. If you have seizures over that year, that medication's not working. Well, how do you know if you try another medication that won't work for you? So they actually took a look at that in New England Journal of Medicine, published in the year 2000. They took a bunch of newly diagnosed, previously untreated patients with epilepsy and started them all on a first medication. And of those patients, that first medication was effective, making them seizure-free 47% of the time. For the rest, the 53% that failed, they took them and put them on a second medication, and an additional 13% became seizure-free. And then finally, adding a third or multiple medications only made an additional 4% of patients seizure-free. So you can see in this scenario here, that same statistic of about 30, in this one, 36% of patients were having seizures despite 3 or more medications. So that actually sufficed as our definition in the realm of treating epilepsy for seizure or seizure medication failure. Basically, if you've tried 2 or more medications over a couple of years and you're still having seizures, you've failed, and your chance of having an additional medication make you seizure-free is probably in the range of 4 to 8% at most. This just summarizes that. Additional medication has only a 4% chance of making a patient seizure-free after failing 2 medications. So it's these 36% of patients, roughly a third of patients, that are still having seizures despite trying 2 medications or more over 2 years, that should be considered for surgery, but I would submit that they actually should be evaluated at a tertiary epilepsy center, such as we have here. And mainly that center can evaluate whether the diagnosis is correct, also evaluate whether the medication dosage is correct, and then as a further benefit, can possibly evaluate for surgical intervention. So another way of looking at that same question, as far as medications versus surgery, if you have uncontrolled epilepsy and you're at that branch point where you've tried 2 medications over a couple years and you're considering trying another medication or whether surgery may be an option, they've took a group of patients and they actually randomized them. They threw their names in a hat. They basically said, okay, you have uncontrolled epilepsy, you're going to have surgery. Okay, you have uncontrolled epilepsy, you're going to have another medication. And they basically took them for a year and just tried them on a new medication or tried surgical intervention. And they took 80 patients and did that with those patients. They followed up at 1 year. The medical group, the group that was just started on a new medication, 8% of those seizures, or 8% of those patients became seizure-free. And in the surgical group, 58% became seizure-free. So I think this shows you the efficacy of surgery in those patients that have failed 2 or more medications. Surprisingly enough, the morbidity was the same in both groups. So with surgery, it sounds rather barbaric. You had 10% morbidity. Also in the medically treated group trying just additional medication, they had a 10% morbidity. And then even more surprising, the mortality was actually higher in the medically treated group. That means a patient taking additional medication, they had one pass away during the study and none with surgery. So surgery is a good option for some patients that have failed medical management. Once again, if a patient's failed at least 2 medications over 2 years, they deserve evaluation at a tertiary epilepsy center. And that would include the specialization of the team approach at that epilepsy center, which includes further history taking, having someone listen to you, obtaining video EEG, which we'll go into to sort of touch on the workup, additional imaging, and then the possibility of invasive monitoring, actually monitoring from inside the skull rather than externally with EEG electrodes on the scalp. So I think we've sort of touched on that. The surgical workup, the foundation of it is the video EEG, basically looking at placing electrodes on a patient's head, having a video monitor in the room, and watching a patient. When they have a seizure, you can watch the motions of the body. That's called the semiology, and it comes from the Greek word semion, meaning sign. And it's the science of interpreting the signs of a seizure, essentially telling from what area of the brain that seizure is starting and then spreading to. That can allow localization of where the seizure is occurring in the brain, which can help decide whether a patient would be a surgical candidate or not. So if you imagine a seizure as being a small campfire, and that campfire, well, let's see, I'm either going to erase this entire slide or, yeah, there we go, good. Got a dot here. Imagine just a seizure starting as the abnormal firing of a set of cells in the brain, and then that campfire spreading out and involving the entire campground, and then finally, if it goes to the entire brain, spreading to the entire forest surrounding that area. So if we watch a seizure, as it starts occurring, it will be sending abnormal electrical signals from that area of the brain, and you can actually see that in some of the motions of the body or in what a patient's doing. And that can give you an idea where that campfire is before when it may be too late when you just see the forest fire. You have no idea which campground it came from and who is liable. That was just a legal joke. So these auras can also be localizing, and that also the careful history taking of a patient, and that's where I think some of the true credit to this epilepsy program lies, is with just the careful details that are drawn out in 45-minute or 1 hour, and I'm probably even cutting you short on some of your visits, time in front of Dr. Passaro and going over what's going on. And then we go to MRI. MRI provides the best images of the structure of the brain. Basically, an MRI is not enough. So let's say you're up in Timbuktu, you have a seizure, they send you down to the local 0.2 Tesla MRI machine that's run out of the back of someone's truck, and they get the scan done and they say, all right, you had your MRI. And it doesn't show anything, all right, but it looks like one of those old Atari video games. So getting the proper MRI, which means with an epilepsy protocol, and I've seen this in the literature one time and I thought it made sense, MRI actually should stand for minimal required imaging. So getting the right MRI of a sufficiently strong magnet, and not only that, but the sequences that actually allow evaluation of the different structures of the brain that are oftentimes critical in epilepsy is very important. So getting the right MRI, and also that's one of the benefits of coming to an epilepsy center, is you're going to get the right type of study done. This here shows an MRI, and basically this just shows one of the more common causes of epilepsy, at least complex partial seizures, and that would be mesial temporal sclerosis. So this here is a slice of the brain looking at someone face on, and so you're looking at them sliced straight down, and you can see how it's almost like an anatomic picture from a textbook. You essentially have the brainstem down here, and then the brain itself above, and you have these two structures here, which are called the hippocampus. Both these structures are responsible for encoding short-term memories, and you can see how this structure here is slightly larger than this structure here. You do an additional sequence, and you're able to pull out this abnormal signal in that structure there that basically cinches it that this patient has mesial temporal sclerosis. So once again, if you had that MRI in the back of the Ford truck, you may have never found out that this was actually there. Then we also have the team approach, which means that in addition to getting the correct MRI, getting the correct neurologist listening to your story, and the video EEG deciding where the seizures may be coming from, the area of brain where the seizures may be coming from may not be functioning normally. And by putting someone through a battery of tests, and that can be testing of language, testing of intelligence, testing of their memory, you can oftentimes tell where the brain is not functioning properly, and that can give you a hint as to where the abnormal electrical firing is just sitting there and interrupting the patient's normal patterns. Okay. In addition, we can do WADA testing, which is to shut off one half of the brain at a time. So this view here, this image here, is actually, once again, looking at a patient straight on. You've heard of cardiac catheterization, where you put a catheter up into the heart and you're going to look at the blood vessels of the heart, and they do that commonly if someone's had a heart attack. They want to see if the vessel is partially closed and see if they can open it up. We can do the same thing for the brain. You take a catheter in the groin, park it up in the neck. You just inject a dye that flows through the blood vessels of the brain, and you actually just shoot X-ray images as it flows through. So this shows the dye flowing through the blood vessels of the brain. And we can do that. In essence, we can do it to one carotid artery and then the other, and you can see how you just get dye into one half of the brain. Well, if you inject sodium amytal or Brevitol or a sedative into the one side of the brain, you can actually turn off half the brain. And when you turn off half the brain, we can test the other half of the brain as to its function. And this helps us decide the side of speech dominance, and in some cases evaluate memory in a patient as to whether how functioning their memory is on one of those hippocampuses that I showed. Oops, now I did what I claimed I would do earlier. There we go. Let's see. Yeah, so we can essentially shut off one hippocampus at a time and test memory in a patient. And then there's access to further imaging. So we touched on MRI, and MRI can show structural abnormalities pretty well. But there's also metabolic abnormalities that are associated with epilepsy. And if we take PET imaging, this looks at the metabolic usage of glucose in the brain. And essentially, if you have an area that's causing seizures, it's oftentimes not going to be working properly, and you'll have lower glucose uptake in between seizure episodes. And that lower glucose uptake will show up. You can see the rim of cortex around the outside is bright white. It's the brain's using lots of glucose. And we can see this little area where it just drops out. That's a hint that there's abnormal glucose processing in that area of the brain. Okay? So that can help determine where the seizures may be coming from. This is SPECT imaging, and SPECT imaging is essentially looking at minute changes in blood flow to different areas of the brain. When you have a seizure, that area of the brain is firing abnormally. It's going to be using a lot of energy, and the blood flow will actually increase to that spot, just like if you were working your leg out and you can feel that muscle after the workout, and it's going to feel warm. Okay? Same thing in that area of the brain. It's firing abnormally, increases blood flow to the area, delivery of oxygen to the area. That change in blood flow can be picked up by SPECT imaging, and it also can be a hint as to where the seizure is coming from. Okay? And then there's taking a patient at rest, where that, as I mentioned earlier, with PET imaging, you may have an area of the brain that's not processing things correctly. It's actually blood flow may be decreased slightly compared to the surrounding brain. You take that image and subtract it from the time period when someone's actually having a seizure, where the glucose uptake is increased, subtract the two, and it'll give you a few specific dots where the biggest differences are in the brain. So this would be an area that would be very suspicious for where this patient's seizure onsets may be coming from. Okay. So this here, you can superimpose those on the patient's MRI, and this gives you an idea. There's maybe two different spots that this patient's seizures could be coming from. All right. Magnetoencephalography is essentially looking at, instead of electrical signals outside the skull, this is looking at magnetic signals outside the skull. And I just like showing the picture. This gives you very accurate three-dimensional pictures of the dipoles of abnormal firing, abnormal electrical vectors in the brain. And so let's say in this patient, they can also superimpose that on MRI, and you can see that this area here, eyeball being up in front, and we're looking at the side of the head sliced this way. You can see the eyeball here, the nose would be a little bit deeper into the picture, and then looking at the side of the head, you can see that this area, the frontal lobe here, would be suspicious for a possible area involved in seizure activity. So as we go through the workup at the Epilepsy Center, we have certain situations where all these things that we've just shown, everything matches. Every study that we do looks like it's the same area of the brain causing the seizures. In that, we have a pretty good hypothesis of what area would need to be taken care of with surgery in order to make someone seizure-free. So that would be one possibility. The site of seizure origin can be identified. Then we have the other possibility that something doesn't match. We do all the studies and something doesn't make sense. So we do, let's say, video EEG, the neuropsychological testing, WADA testing, it all looks like a specific area of the brain is where the seizures may be coming from, and then all of a sudden the MRI shows a big abnormality back here. And and we have to say, okay, all bets are off. Something is not right here. And that's where invasive monitoring can come into play. And essentially, invasive monitoring is a way of monitoring from inside the skull. And there's a few different methods to do it. It is something that can help out to figure out where seizures are coming from. I don't know. Don't show that one, huh? Okay, let me. Let me. So in essence, we can open up. This is one way of doing it, and this is basically invasive monitoring with grids. It's basically opening up the skull, putting grids right on the surface of the brain, so we actually monitor the electrical activity coming directly from the brain. As you may have heard in past or prior lectures or from reading on the internet, that when you measure an EEG from the outside, when you have the surface electrodes on the scalp, you can imagine you're pretty far from where the electrical activity is on the brain. And your signals are pretty weak, and that's why we get all those squiggly lines and get reams and reams of paper or computer data of what's going on. By putting electrodes right on the surface of the brain, you can measure small fields and get much better, stronger fields to be able to tell what's going on. Okay, so real quick, close your eyes. All right, there we go. Okay, you can open them now. So this one here is, let's say, the superimposed CT data on the surface of the patient's MRI, showing where a grid was laid over the surface of the brain, and each one of these dark spots would be an electrode that's measuring electrical activity from that field in the brain. Okay, you can imagine if we suspected a seizure coming from this area, but we weren't sure because there was also a spot up here, we could lay a grid over this area and that area, close this skull up, close the scalp up, little electrode leads coming out through the scalp, and that patient could be monitored in the room in the hospital for anywhere up from 1 to 3 weeks. And the patient can have 1 or 2 seizures or even more, and we could, with those seizure onsets, we may be able to monitor and find out exactly where they're starting from. 1, identify whether it's one spot or the other, but 2, identify which region within that area is actually the source of the abnormal electrical activity. This one here is showing depth electrodes, and this is where that ROSA, that surgical robot, comes in very handy. It can basically position its arm anywhere over the brain and allow you a direct trajectory down into specific regions of the brain to monitor the surface electrodes that I showed you on the prior slide. Just lay right on the top. These electrodes actually go in and can go into the deeper areas of the brain to look at other possible sources that would be deeper underneath the surface. Okay. So as I said, the patient would return to the floor in the hospital. They'd have the electrode array in the head, and they're monitored for anywhere from 1 to 3 weeks. We can not only monitor from that area, but we can actually test using that same electrode array. So if you have electrodes in the head, you can actually monitor signals coming out, the electrical activity coming out. If you wanted to, you could map out that area of the brain by actually sending small electrical signals in between 2 contacts and actually stimulate those regions of the brain. So we could actually map function around that area. So let's say you find out where seizures are coming from. By mapping that area out, you can then determine, 1, what sort of functional tissue is around the site that's causing the seizures. Okay? And that can make surgery, if it is an option, safer down the road. I'll just real quickly take you through 2 of the more common types of surgery for curing intractable seizures. Once again, it sounds barbaric, surgery for epilepsy, but at the same time, I think if you've talked to anyone, most people leave and go home after seizure surgery anywhere from 1 to 3 days afterwards. It's relatively short stay in the hospital, and this maybe will just take you from start to finish in a case. So let's say this patient here has an abnormality in the brain on MRI, and we find out that the seizures do appear to be coming from that region. And this image here, this MRI view, is a slice like this, looking from the feet up to the top of the head, or you can imagine looking directly down. And over in this region of the temporal lobe, you can see this abnormality in the brain. You could possibly, it wouldn't necessarily do this, but you could possibly do You could take the patient ahead of time before even deciding to take this tumor out. You could take and put an electrode grid on the inside, get a patient out of the operating room, go a week and monitor them, and if they have several seizures, you may be able to tell, let's say the abnormalities here, you may be able to tell from the periphery, the surrounding tissue around the abnormality, where the seizure is actually coming from. So you know if you're going to go in and do surgery for this tumor, that you need to also remove this neighboring tissue because it's the area actually causing the seizures. Okay. You could also do functional MRI, which, as Dr. Passaro was mentioning, we should have here within the next few weeks, right, Jill? All right. Yes, sir. All right. But a functional MRI, essentially, you can do mapping of functional areas in the brain on the MRI machine. Okay. So it's another way of deciding where tissue is functional around a lesion. So in the operating room, let's see, we have the operative team here. We actually use a system that'd be similar to GPS in your car. We do an MRI scan right before the surgery. We load that MRI up into the navigation system. We then register, when a patient's asleep under anesthesia, we register that system with the patient's face. And during the operation, if you take a probe, touch it to the tip of their nose, you'll see on the computer, on the MRI imaging, you touching the tip of their MRI scan. Okay, so you can use that in the operating room to give you very detailed anatomic pictures of the brain that's right underneath in your surgical field. Okay. Then we'd have you'd make an incision on the skull. Oh, sorry, I got to warn you. This one here. So we can actually do stimulation in the operating room. So let's say there is functional tissue surrounding the tumor, and we want to map that out in the operating room. So we can do it with the patient awake and actually talk with the patient and stimulate the areas of the brain and actually make a little detailed map of what function they have. Let's say if the tumor was underneath this area here, what functional regions are around that spot that would need to be protected. Okay, and then we could remove the lesion while leaving all these areas intact. That should be the last one there. Okay. No. I have slides of cookies later on, if that helps. There is a cookie in one of the future slides. So with two of the more common surgeries that we do for seizures, both temporal lobe epilepsy with mesiotemporal sclerosis, the outcomes are anywhere from 70 to 90% seizure-free. So this is a very effective way of taking care of someone's epilepsy. If they have a lesion on MRI, like that abnormality I showed you earlier, an actual tumor in the brain, we have even higher rates, 80 to 90% chance of being seizure-free, and that means a year without seizures and then year beyond year beyond year. So, all right, we got good seizure freedom. What do we have as far as risks? Now, as far as death, very low rate. Okay, we're talking 1 in 400 patients. Okay, serious deficit, meaning a stroke of some sort, 2% or less. Mild transient deficits, 6%. Okay, now if you take untreated seizures, those are not risk-free. As you may know, accidental injuries. God forbid, driving a car and you have a seizure and you go off the road. It's one of Dr. Passaro's best referral sources is US 19. And then there's also SUDEP. SUDEP, basically sudden unexplained death in epilepsy patients, which is, have 24 times the chance of just dying out of the blue than other people. Okay. And then there's the known cognitive decline that can occur over time with uncontrolled epilepsy. And finally, just the issues with being unable to be employed, married, dating. Those things are all something that are under recognized, I would say, in the epilepsy population. Okay. Also, going back to so here we are. We're looking at surgery. Barbaric therapy does have great outcomes, but the risks, it sounds so risky. So we went over the risks of the surgery itself, 1 in 400 mortality. And we went over the risk of, having uncontrolled seizures altogether, which put those on a scale, and the risk of surgery doesn't seem too bad. Well, then you take the risk of just adding in these different medications, and just as that study had shown you earlier, the morbidity actually turned out to be the same in that group of 80 patients, 40 having surgery, 40 having a new medication. The morbidity of both was the same, and actually the mortality was higher in the medically treated group. Okay, so now it doesn't look so barbaric. We also have other surgical alternatives. I don't know how much time I have. I can sort of fly through this. I at least need to show her the cookie slide. This is a vagal nerve stimulator. It's basically like a pacemaker for the vagus nerve. The whole idea behind this initially, clinically they'd found some patients that if they felt their aura coming on or a prodrome, they could rub their neck, or actually in the olden days they would take their hand and throw it in a bucket of ice or throw it into a fire or something like that to overwhelm the brain and actually put sort of the brakes on the brain. And that's the idea right now. You stimulate the vagus nerve, which has tremendous inputs into the thalamus, and that sort of globally sedates the brain or calms the brain down. First trialed in 1988. Basically, there's your cookie. All right.
You promised.
It's it's very small. Actually, the newer one is about even 2/3 of this size. The electrode leads go on the vagus nerve, and then the pacemaker portion of itself goes right underneath the collarbone or over near the axilla, armpit. Sorry. Basically a chest X-ray with one in position, and you can see the little leads up on the vagus nerve in the neck. So 1/3 of patients will have a 50% reduction in seizures, 1/3 of patients will have less than 50% reduction in seizures, and then 1/3 of patients show no improvement at all. There's a 20% that'll have a 75% reduction in seizures, and about a handful, 5% or so, that'll have seizure freedom. Okay. And then there is some side effects, truly very well tolerated by most patients. It's possible to get hoarseness or change in your voice, sore tickling throat, shortness of breath or feeling like you can't catch a breath, and then the fact that a battery replacement needs to be performed every 7 to 10 years. Battery replacement is just like a pacemaker for the heart, where you basically just you can do it with just local anesthetic. Open it up, disconnect the leads, put the new one in, and close things back up. It's literally outpatient surgery. Responsive neurostimulation. So this is available, has been FDA approved, and essentially this is placing electrodes on the surface of the brain near where the seizures may be coming from, so you can monitor that area of the brain. And by monitoring the electrical activity, the pacemaker, the brain of the unit can actually determine when seizures are starting in that spot, and it can send electrical stimulus to that area and zap it and knock the seizures out before they start. I'll go forward a couple slides here just to get by those quick. Geez, I'm gonna have to, I'll stand in front of this. So the idea is that you end up having monitoring of that area of the brain, the seizures starting up, the little unit measures that and knows that it's coming on and sends an electrical signal to the brain. That signal you can see here, and it knocks the seizures out. So in conclusion, roughly 1/3 of patients are going to fail medications. Seizure surgery has a very good rate of outcome as far as making someone seizure free. Much better than trying an additional medication, okay? And every patient who's tried at least 2 medications for at least 2 years and is not having their seizures controlled deserves a evaluation at a tertiary epilepsy center. All right. And Bayfront is one of 5 in the state of Florida. So thank you all, and maybe the whole group can come up for questions at this point in time.